Hi there, my name's Bob Furlong, and today we're going to be talking about the use of ultrasound in the evaluation of the deep venous system. Approximately 250,000 new diagnoses are made a year of deep venous thrombosis, or DVT, and approximately 50,000 deaths will occur annually from thromboembolic disease. Patients will generally come in with complaints of pain, swelling, and erythema of their lower extremities when they present with a DVT. And as you can see in this picture here, the patient's right leg is markedly more swollen than the left, and it's kind of developed this sheen. You can see here the reflection from the light as the leg has become more swollen and the skin becomes more stretched along with it, and we can also see the redness that's developed in this patient's leg here. And as the name implies, these DVTs are due to an actual thrombus that forms within the deep vessels of the venous system in the lower extremity here. So next we'll talk just a little bit about the pathophysiology behind the formation of these thromboses. And if you'll recall from your pathology course, Virchow long ago came up with Virchow's triad, which was a theory that stated that there was three main things that could contribute to the formation of these thromboses. And if any one of these things sort of got out of whack, then we could end up with one of these thromboses within the venous system. And those three things are endothelial injury, hypercoagulability, or venous stasis, also shown here as abnormal blood flow. And a couple examples, hypercoagulability could be due to maybe a malignancy in somebody or someone with factor V Leiden or antiphospholipid antibody syndrome. We also have venous stasis, which could be due to really anything where patients are sedentary for long periods of time. If their job maybe gives them a propensity for that, such as being on long hauls on the road as a trucker or being a pilot, or maybe a patient has just had surgery and is at particular risk post-op for developing a DVT from venous stasis. And then endothelial injury can really be due to anything that disrupts the endothelial lining, whether it's a catheterization procedure or just the abnormal blood flow sort of shearing the endothelial lining off the vessel. So these thromboses start as a formation of microthrombi, and those microthrombi grow when the rate of the coagulation exceeds the rate of thrombolysis. And about 10 to 50% of these thromboses that form can propagate to pulmonary embolism, which is the main thing that we're really concerned about when someone comes in with a DVT. So we will talk just a little bit more here about the presentation of a patient with lower extremity DVT. As we said before, they'll come in with the erythema or redness. They'll come in with edema oftentimes, which is the most specific finding that we have for presence of a deep venous thrombosis. And they often come in complaining of pain in the affected lower extremity. Leg pain actually occurs in 50% of patients, and then tenderness to palpation of the affected side is in about 75% of patients, and it's usually confined to the calf muscle or to some point along the course of the deep venous system that's affected. You may have heard about Hohmann's sign before, which is a sign that you can elicit by dorsiflexing the patient's foot on the affected side, and if they feel pain within the calf of that affected side, that's supposed to be a positive Hohmann's sign. But that sign has fallen from favor because studies have shown that the positive predictive value and the negative predictive value are both right around 1, which isn't really helpful in determining whether or not a DVT is actually present in these patients. One other thing to say here is that these patients can present with usually unilateral symptoms, but sometimes they can have bilateral presentation if the clot that is formed is high enough up within the deep venous system, such as in the pelvic vessels or in the inferior vena cava. We'll talk a little bit here about how we actually have to diagnose these patients. So 46% of patients were shown in this study by Hager to have classic symptoms but negative venograms, or In other words, no DVT present when they underwent these imaging studies. And in another study, as many as 50% with image-documented DVTs lacked these specific symptoms. So really, sometimes the symptoms don't match what the imaging is showing you, and you have to go by what the imaging actually says. So in order to rule out DVTs, you need to do some diagnostic testing. So that brings us to what we're actually going to be talking about here today, which is the sonographic methods of evaluating the deep venous system. There's sort of two different camps here on the actual use of ultrasonography in evaluating the deep venous system, and those are two-point ultrasonography versus whole leg ultrasonography. So which one's better, and which one are we going to talk about today? Well, in 2008, a study comparing the two methods showed that in patients with a positive D-dimer, the two strategies were equivalent in the evaluation of suspected DVT. And this is good for us because it basically tells us that in a busy emergency department, when you need to be doing things as efficiently as possible, we can use this two-point ultrasonography of the leg pretty confidently, just as we could use the whole leg ultrasonography to rule in or out the presence of a DVT. So we're going to talk about the two-point ultrasound here today. And this here is an image of the two-point ultrasound versus the whole leg ultrasonography. On the right there, we actually have the 2 points of the leg that we're going to focus on, which is the common femoral vein and the popliteal vein when you're doing the two-point ultrasound. So there's some questions that we actually need to answer here too when we're using the ultrasound probe to detect the presence of a deep venous thrombosis. The first one is, does the common femoral vein fully compress when we push down with the probe? And secondly, does the popliteal vein fully compress when we push down with the probe? And secondarily, you can also use colored Doppler to evaluate the deep venous system as well. And so the main thing you're going to be asking is venous flow actually identifiable with the colored Doppler? So here we're going to take a look at the anatomy of the deep venous system. We'll just quickly do a little review here. So we see you'd have your IVC up here, which isn't pictured, and then the IVC will come down and split into the iliac veins, and then the iliac will continue as the common femoral vein once it crosses over the inguinal ligament there. So this is the first point where we're actually going to be evaluating for the presence of a DVT with the ultrasound probe. And the first tributary that you have that branches off of the common femoral vein is this greater saphenous vein here. And we'll also see that when we look at images later. One thing to keep in mind here as a landmark is this common femoral artery, which is going to be running lateral to your common femoral vein. And if you've ever heard the mnemonic NAVAL, which says nerve, artery, vein, empty space, lymphatic system, going from lateral to medial, that's a good way to keep in mind the order of which you should see the vessels in this region here. So always be looking for that femoral artery lateral to the common femoral vein. And then as the femoral vein progresses down, it gives us another tributary, which is the deep femoral vein, and then the superficial femoral vein. Don't be fooled here by this word superficial. The superficial femoral vein is still part of the deep venous system. It's just sort of a misnomer here. And then that superficial femoral vein will continue down into the back of the knee, where it will actually course posterior to the popliteal artery here. That superficial femoral vein will turn into the popliteal vein and sit posterior to that popliteal artery. So this here is an image of basically looking at the variability in the areas that these DVTs can actually present in. So that's basically what I want you to see from this image, is that there's no cookie cutter way that you're going to actually see a DVT. It can involve the popliteal alone, or popliteal and part of superficial femoral, or the whole leg, or it can be just the common femoral. And really, this also serves to show you that if you're using the two-point ultrasound technique, you're going to catch these DVTs because all of these are involving at least the popliteal or the common femoral vein. So here we're actually going to start looking at some ultrasound images of these vessels. So I'm going to kind of orient you here a little bit. This is looking at the common femoral vein, which is right here on this ultrasound image. And to orient you, the probe is up here. We're using a high frequency linear probe, which is great for looking at vasculature. And you get this flat appearance here on the screen because the probe is flat as opposed to other probes which have more of a curved surface. So this is the surface of the leg right here, and you're getting some of the superficial tissue here, and then we have our common femoral artery here, the common femoral vein, and then this is the greater saphenous vein. So we can see the level we're at here on this cartoon on the right, we're right at the level where the saphenous vein is starting to branch off of the common femoral vein. So you'll see this, and if you were to scan down the leg, you would see this vessel sort of moving out on the picture like that. And then another thing to keep in mind is when you would actually be looking at this on a live video image, this vessel here, the common femoral artery, might be pulsating as well, and that's an easier way to distinguish between the veins and the arteries. One other thing to say here, before I had talked a little bit about how the common femoral artery is lateral to the common femoral vein, and that's true most of the time, but you have to keep in mind that everybody has some variability in their body, so just be heads up for looking for the actual pulsation in the vessels so you can distinguish between the two vessels more easily. And then here we're looking at the popliteal vein. So as we can see in our cartoon, we're down here at the knee, and this is really the posterior surface of the knee right here at the top of the image, because for this we're going to come from behind the knee. And we're looking down, we have our superficial tissue, and then here is the popliteal vein and the popliteal artery. And again, the popliteal artery will be pulsating, the vein will be compressible, or it should be compressible if there's no DVT present. And remember this little saying here, the pop comes to the top in the popliteal fossa. So your popliteal vein is going to be on top in this image when you're looking from the posterior aspect of the knee. So we'll talk a little bit about probe selection. I sort of gave it away before, but we're going to use the high frequency linear array probe because that's the best for evaluating a DVT. It gives you a nice crisp, clear image that has better resolution with the higher frequency probe. The one caveat there is for larger or maybe a patient who's severely edematous, you can use a lower frequency probe. You're not going to get as crystal clear of a picture, but if there's a ton of tissue in the way that's preventing you from actually looking at a depth where you can visualize the structures you're looking for, you may have to use a lower frequency probe which can penetrate deeper. And this here is just an image of our high frequency probe here. So we'll talk a little bit about how we're going to be positioning our patients as well. And for the common femoral vein, what we're going to do is just have the patient lie on their back in the supine position, and we will have them slightly flex the knee and the hip. And then we'll have them externally rotate their leg out so that you have sort of a view of the medial surface of that leg. And then we will start scanning where we said before for our 2-point scan in the region of the common femoral vein up top there on the leg. And for scanning the popliteal region now, the way that I like to have the patients lay, which I feel is usually the easiest for both the patient and yourself, is to have the patient roll over onto their side and bring the leg that you're going to be scanning forward there. And actually, you can have good access to both popliteal regions when you have the patient do that, which is shown in this picture on the left here. Now, you can really get at the popliteal region from a variety of different positions, and it will depend on what's most comfortable for the patient and yourself, as I said before. We have a population of patients who's oftentimes obese and unhealthy, and sometimes they have difficulty moving, so it's it's hard for them to get into certain positions. So when I can just have them roll like this, I find it easier than doing something like having them dangle their legs over the bed. But in sort of a smaller patient who's more mobile and you can kind of maneuver their extremities around a little bit more easily, this could be an option as well, just having them dangle their leg over the bed and scan from the backside of the knee there. Another option is to just have them simply bend their leg while they're laying supine and scan from the back side. You just have to keep your probe's orientation in mind when you're doing this and recognize where the indicator is because you're kind of coming from an angle that might be a little counterintuitive. And then finally, you can have the patient lie prone if they're comfortable enough to do that, and then just elevate the leg on some blankets there and have a pretty easy access point to get to both popliteal regions there. So we will actually talk about scanning technique now, and here we just have another image of where we're going to start our scan for the common femoral vein. So we're going to begin in that region, just distal to the inguinal ligament, which runs from your anterior superior iliac spine down to your pubic tubercle. Excuse me, and we're going to line the probe in a transverse position to that common femoral vein. And you're going to apply pressure at 1 centimeter intervals to assess for the compressibility that you're looking for on the ultrasound image. So here is an actual, this is a cartoon of what that compressibility might look like. So if a vein is fully compressible, it's going to appear as a thin line on the ultrasound image when pressure is applied. So you see here, you go from having all your patent arteries and veins here, you push down with the ultrasound probe, your artery should stay patent there, and then if there's no DVT present, you'll see just these thin lines, or you might even kind of just see the veins completely disappear and you won't see those thin lines at all, but you'll still have your pulsating artery present. So here's an actual image on the right side before we compress the arteries and veins. We see our femoral artery here, the femoral vein, and then once we push down with the probe, you see how you know that you're pushing down, you get this distortion up here compared to over here where the artery is sort of making the tissue bulge here, and then you completely lose the vein. You can sort of see this little slit here where the vein was, and this is what it would look like if there's no DVT present. And this here is a positive common femoral vein DVT. So this here is the common femoral vein, and this is without compression on this side here. And then as we compress down, you see the artery stays patent, the vein stays patent as well. And what you can see here is that there's this region in this vessel, sorry, there's this region in this vessel here that's sort of hyperechoic. And that is the actual clot that's present in there. And sometimes you'll see those clots and sometimes you won't. It sort of depends on the state of that thrombus. Older clots will become more hyperechoic as the clot ages. And really, when you're looking though, the only thing you can say with certainty for ruling in a DVT is whether or not the vein compresses. That is the one thing that will give you a certain evaluation every time. You cannot say, oh, I see a clot or I don't see a clot, because for a variety of reasons, actually visualizing a clot or what you think may be a clot is not as accurate a tool as just using the compressibility of the vessel itself. So we'll talk a little bit here about the scanning technique for the popliteal vein as well. First, you're just going to reposition the patient for the popliteal exam, like we talked about before here. Just have them roll onto their side if that's easy enough. And again, scan in the transverse orientation and 1 centimeter intervals. So we're going to be looking for this double ice cream scoop sign, and that's what's normal. And of course, there can be some variability as well, where the popliteal vein could be like a double vein instead of just the one single vein here or something like that. But this is what you should normally see. So again, here we're looking at our popliteal vein over the popliteal artery, and this is without compression on the left, and then when we compress it down, you see your artery here, and we've completely lost the vein. Maybe right there is where the vein is, but it's hard to tell. Sometimes you just completely lose it. And then here, this is a positive DVT in the popliteal vein. So here we see it's without compression, and then here when we compress the tissue down, we still see this patent popliteal vein here above the popliteal artery. And in this one, just like I was saying before, note that you don't really see much that looks like a clot in this vessel. So you just are going by the fact that the vessel is not compressing when you're pushing down with the ultrasound probe. So we'll talk a little bit here about color Doppler and how that can be used in the evaluation of a DVT. So what color Doppler is a way to measure the frequency shift from approaching and or receding red blood cells, and that gets translated into blushes of color that are blue and orange on your ultrasound screen. So basically, usually there's a little box that you can maneuver around the screen and place over the vessel that you want to evaluate, and then you'll see these blushes of color come in if flow is present. And it's helpful to actually identify whether absence or presence of blood flow is there. But keep in mind again that this can't give you a definitive diagnosis on the presence or absence of a DVT. It's just a helpful adjunct to add to your use of compressibility and actual visualization of the blood vessel. So there's three different sort of characteristics or tools that we use within this color Doppler to describe and examine further patients who might have a DVT. And the first one is called augmentation. And what we're doing is we have that Doppler window placed over the vessel that we are interested in, and then the examiner actually squeezes the patient's calf, and if the vessel is patent, a blush of color will fill the vein. And so if it's absent, that might key you into some impedance in the flow of blood through that vessel. The second tool that we use is called spontaneity, and all that really is observing the vessel over a certain period of time to check to see if flow is occurring without mechanical manipulation. So that's just the normal flow, normal pulses of blood that come through that vein that you would see. The third thing that we talk about is phasic variation, which is just the variation of venous flow during your respiratory cycle. And it's kind of counterintuitive, but the flow increases during expiration and decreases during inspiration. So this here is just a picture of a patent common femoral vein, femoral artery, and greater saphenous vein. And as you can see here, the blood in the artery is more of this reddish color, and then the blood in the two veins is more of a cooler color, like the blue and green that's receding away from us, while this is coming towards us here in the artery. This is what you might see if there was some occlusion within the vessel there. So you see here some patency and some smaller veins here, maybe the artery here with the red, and then in this huge vessel here, there's no flow going on that we can see with the Doppler. So that might clue us into the possible presence of a venous thrombosis within that vessel. So some things to remember here, and these are pretty important tips that will help you in actually diagnosing a DVT. The only way to confirm the presence of a DVT is by visualizing a vein that is not fully compressible. And vice versa, the only way to rule out a DVT is when the vein is fully compressible. And so we'll talk about some things here that don't confirm or rule out a DVT, and that's the presence of flow identified on Doppler, direct visualization, or non-visualization of an actual clot. So those things can all be helpful in your determination of whether or not a clot is present and can kind of give you clues towards the right answer, but you can't actually use any of them as definitive criteria for the presence or absence of a DVT. And finally here, we'll talk about some tips for scanning. So one thing that could be helpful if you're having a hard time actually finding the vessels at all is placing the patient in reverse Trendelenburg. You want to lower the feet of the bed and use gravity as your friend to get the blood flow to come down to the legs as much as possible to distend the vessels that you're looking at to get an easier time at actually having them visible on your ultrasound screen. The next one is just find a position for the patient that works for the patient and that works for you as well. Positioning is everything. Have the bed up high enough so that you're not killing your back bending over. Have the patient in a position where they're going to be comfortable sitting for a few minutes so you can get an accurate scan done. And just do what's best for everybody in that situation. Next, if you can't find a vein, try using less pressure. And I didn't really talk about pressure much before, but there's a possibility that if you are just seeing a pulsating artery, that you are simply just using too much pressure, and sometimes even the weight of the probe is enough to collapse a vessel, especially in the popliteal region. So if you can't find that vein, just ease off a little bit on the pressure until you're almost pulling the probe off of the skin, and see if that helps bring that vessel into view. And then finally, make sure the probe is completely perpendicular to the vessel for a proper assessment. If you have the probe at some oblique angle, you're not going to get a great representation of what the vessel looks like fully compressed or not compressed at that particular point. So you need to make sure it's completely transverse to the point you're looking at and then apply the pressure. That's it for our talk on evaluations of the deep venous system using ultrasonography. I hope you learned a lot, and stay tuned for more.